My name is Leonard Abramsky, and I am the co-chair of the 2020 UJ campaign. I first of all want to thank all of you for joining us for this webinar on our medical professionals who are our front lines, really dealing with everything we're dealing with. But before we get into that, I just want to spend a couple of minutes with you to explain to you what we at UJ are doing this year in order to address our large community needs that are coming forward. We have launched our campaign at a quickened pace, obviously, and we are going forward to address all of the community needs. The initial community needs that we are facing are enormous. We stepped up before Passover. We started to pack meals. We started to arrange food for the elderly, dealing with the homeless, and dealing with all sorts of issues that are facing our Jewish community. Our Jewish community is no different than the rest of the community and everything that everybody else is facing. So as a result of that, we have really had to pivot our campaign this year and really step up in order to make a difference for our Jewish community, which is truly facing an existential threat to many of our community agencies that we all rely on so importantly, whether it be Jewish Family and Child Services, Jewish addiction, the day school system, the camping system, even our JCCs. Every one of those is facing financial threat, which is causing a problem for our community. As a result, we have launched our community campaign and pivoted to look at our needs, and we've identified over $85 million in needs, which is an additional 25 over our traditional needs that we have always faced. We are reallocating capital within our $60 million campaign and raising an additional $25 million to help the Jewish community of Toronto. So all we're doing tonight is that we're allowing you to become more educated, but we're also encouraging you, if you feel so inclined, there will be a link provided at some point, and feel free to reach out to any of the UJ professionals, myself, or go online and donate and really make a difference to our Jewish community. And with that, I would like to turn it over to Dr. Randy Wax. Dr. Randy Wax is an associate professor at the Department of Critical Care Medicine at Queen's University, an assistant professor in the Department of Medicine at U of T, and a critical care physician at Lakebridge Hospital. Dr. Wax will be moderating our esteemed panel tonight, and I will turn it over to him. Thank you so much for your time, and please stay safe and be healthy.
That's great. Thanks very much, Leonard. I really appreciate the introduction to the event this evening. What I'd like to do first is just going to go through introductions for the panel, just so everybody knows who's joined us. We're very lucky to have a fantastic group of physicians to comment on the COVID-19 pandemic. And we've received a number of questions in advance from participants on this webinar. And so we're going to try to go through as many of those questions as we can, and we'll try to direct it to the appropriate experts that we have on the webinar. But I think everybody's going to have an opportunity to speak as we go through the different questions this evening. First, why don't we start with Dr. Matlow. Anne, did you want to give a quick introduction for yourself? Is that okay? Oh, you're on mute, Anne.
Hi, everyone. I'm Anne Matlow. I'm an infectious diseases physician by training, an internist, and spent 22 years at the Hospital for Sick Children doing microbiology and infection control, and had experience with SARS while I was there. And right now I work at the Faculty of Medicine in postgraduate medical education, helping to deploy some of our trainees to work on the front when they get working with beyond their usual area of expertise.
Thanks, Anne. We're very happy that you're able to join tonight. Gary, do you mind introducing yourself for a sec? Oh, you're muted as well, Gary.
Okay, so good evening, everybody. My name is Gary Mann. I'm an emergency physician working at Lakeridge Health, Ajax, and Pickering Hospital. Been there for almost 40 years. And I am also the emergency physician lead for Ontario Health's Eastern Region, Central East sub-region, where I work very closely with Dr. Wax on all things emergency medicine and critical care.
Perfect. Thanks a lot, Gary. And Barry, go ahead. Did we lose Barry? Oh, you're muted as well, Barry.
I'm sorry, I think you're going to have to tell every person, sorry. So my name is Barry Pakes. I'm a public health and preventive medicine specialist physician. I work in local public health as an associate medical officer for health in the Toronto area. I'm the program director of the residency program in public health and preventive medicine at the Dalhousie School of Public Health, and also the global health lead at postgrad. And I do some emerge work, and I'm right now in a COVID assessment center as well.
Perfect, thanks. And how about Dr. Slutsky?
Hi, I'm Art Slutsky. I'm a pulmonary critical care physician, mainly doing research now. My major interests have been mechanical ventilation and ARDS. And until 3 months ago, no one knew what I was doing. But now they know what mechanical ventilation is all about.
Yeah, it's great, Art, that you're able to join us tonight. And for those who don't know, Dr. Slutsky is certainly a world expert in mechanical ventilation. And we've learned a lot about some very odd aspects of COVID-19 and how we have to use ventilators in this disease. So it's great that you can join tonight as well. So we're going to just jump right in to some of the questions that we have. The first, I'm going to maybe get Dr. Matlow and Dr. Pakes to help us out with this. There's a lot of confusion or initially some uncertainty about mechanisms of transmission for this particular coronavirus and what that's meant for both infection control within hospitals, because I know we have a number of healthcare providers joining us, and in sort of primary care settings, long-term care facilities. And just wondering, maybe, Anne, if we start with you, and then Barry will get you to comment as well, just your thoughts on what we know now and what we still don't know about mechanisms of transmission and what that means for protecting healthcare workers and patients.
Okay, so happy to start. So the feeling is that the SARS coronavirus 2 or COVID is transmitted by droplet contact. So it's large droplets that are released when you speak or cough. There's always large droplets, but along with that, there can be small droplets that can travel a bit of a longer distance. But the bulk of the particles that are emitted when you talk and cough are large particles that fall very close to where you're at. We know that there are aerosol generating procedures that are higher risk, that have the smaller particles. So infection control implications for those kinds of procedures like intubation and bronchoscopy, et cetera, are much more severe. But for the general situation, it's droplet contact spread. Aerosolization, as I say, small particles are produced, but to date, although it remains theoretical, there's really no evidence for transmission by the airborne route. What do you say, Barry?
Yeah, no, I don't have much to add to that, other than that from our end in public health, communicating that to the public, explain to people really this is person-to-person droplet, and then having everybody citing all kinds of things they've read on the internet about, it's on cardboard for 72 hours, for 7 days, or, we heard it can be aerosolized here and there, all of which, as you pointed out, and is true in theory, and there may be evidence here or there of it, but it's largely droplet, and that is how we're approaching it, from whether it's hospital IPAC, whether it's in primary care or our public health messaging.
Yeah, absolutely, and certainly for those of us who are participating in those aerosol generating medical procedures like intubation in the hospitals, we've obviously had to take a higher level of precautions for those very specific and isolated procedures. But for the most part, it's been we haven't had to worry about that as much. And did you want to comment a little bit about beyond, for example, the mechanism? What that means for example, for healthcare providers to start with about personal protective equipment, and what are the expectations? What should they be really prepared to have to be able to look after patients safely?
Right. So general taking care of patients would involve a surgical mask. So we're talking about patients who have COVID. Randy, is that what you're thinking? So
Sure.
A surgical mask for routine care, eye protection, be that goggles or a face shield. you should wear gloves and as well a gown and or some kind of protective top garb, and be very careful not to get any droplets or anything on your skin. It's very important to watch a video, watch a YouTube about how to put it on properly and how to take it off properly, because you, as I say, you don't want to contaminate yourself. And obviously good hand hygiene when you've done all that, to make sure that you're not taking home any bugs from touching your protective equipment, and disposing of them very carefully in the bin so nobody can get contaminated from what's in the bin.
Absolutely. And it's been interesting, certainly for many people who work in the hospital environment or in primary care who have used personal protective equipment before. It's been really, really interesting, the comments. One of the things that we've added, certainly for our high risk procedures, are having infection control coaches, safety coaches. Sometimes people could, because you talk about donning and doffing PPE, they've used the term doffacers for people who are helping to watch. And what's been interesting is if somebody hasn't watched themselves put on or take off the personal protective equipment, sometimes you don't realize some of the mistakes that you've probably been making for years. And so it's been interesting to get the feedback from people, certainly the first few times, or if you haven't done it in a while, getting somebody to watch you put it on and take it off to make sure you're doing that properly is probably not a bad idea.
Yeah, I would just add that there was a study at U of T that showed that 30% of the time there was an error in doffing, in taking your equipment off. So speaks to your point of having a buddy or an safety officer watching.
That's great. And Barry, from obviously you're in a clinic today where you've been looking after or assessing potential patients. Any comments on, for example, outside of the hospital environment for physicians or other healthcare providers who are working in the community setting? Any comments or advice you wanted to give about PPE or any other protective strategies to keep healthcare workers and patients safe?
Sure. I mean, we got a lot of, even though we in public health are not the ones providing the PPE, we certainly had an awful lot of physicians, and rightly so, contacting us for PPE that they didn't have. And that's now, the Ministry of Health is handling that, certainly. So getting it is a big thing, and learning how to put it on and off is important. And really what everyone does just need to get used to, especially people who work in primary care or mostly in a clinic environment, have been working there for an awfully long time. All the things you don't think of. So donning and doffing, certainly we talk about a lot, but everything from light switches to door handles and just the usual stuff you do, it really does take a week or two to get used to working in an environment where you're conscious of this, and maybe the others on here work often in that, and I work in Emerge as well. But to do that in a clinic setting, it takes a long time to get used to, for yourself, for your staff. And I think it's important to keep in mind that a significant proportion, somewhere between an eighth and a tenth, or a little bit more in Ontario, people who've tested positive have been healthcare workers. Very few have become severely ill, but it's a significant concern for everybody, and we need to take care of ourselves to take care of other people.
Absolutely, I'd agree. Maybe to sort of move out a little bit from the healthcare side, because a lot of questions trying to understand how personal protective equipment and masks fit in for use in the general public. And so I think sometimes people get confused about what healthcare workers are potentially wearing to look after patients with COVID-19, and what people in the public might be using in terms of masks, and how that may or not help provide some protection. Particularly the confusion about, if I'm wearing a mask in public as a member of the public, is my mask protecting me from other people, or is my mask protecting other people from me? And I don't know whether Barry, maybe you want to start comment, and we'll get some comments as well about how does all this fit, and what kind of messages should we be sending to the general public?
Yeah, so I mean, I'm sure everyone is aware that our messaging around this has shifted somewhat over the past couple of weeks. The core of the message actually hasn't changed a lot, and it takes a little bit of convincing when you're doing media, which I did a couple today, which, haven't you changed? Well, we've been pretty clear from the beginning that the masks are protecting other people from you, not you from other people. The change has been how wise or necessary we think it is in public. And lots of people have been saying, and in many ways rightly so, that the countries that have managed this well are those that have had widespread mask use. That may be because of that, or despite that, or just associated with other things. So I don't think it's the end all and be all. But the federal government has moved towards a permissive stance with respect to masks, just for general use. And I think we're moving more gradually towards it as part of the reopening process. And I think we'll see over the next couple of weeks that the guidance from Ontario will become a little clearer as things open up. If nobody is that much, then it's not absolutely necessary. For essential workers and those who are out there, many people are still using it, and gradually that's going to be increasing over time. So I think we'll see some changes there.
Right.
If I could,
go ahead, Anne.
if I could make a quick comment, one has to differentiate between, and I'll use this term, source control versus protective equipment. So source control is when I'm going to use something because I'm infected, I'm the source, and I don't want you to get it from me. And that's about universal masking, where it's one option is using a cloth mask. Protective equipment are surgical masks because they filter the air. Cloth masks don't filter the air. So they're not completely interchangeable one for the other. And I think that distinction is important to make. We can talk about it later if we have time, but I wanted to get that point in to add to what Barry said.
Thanks. Oh, that's great. That's great clarification for people. And just one other quick question for you, and before we move on, within hospitals or healthcare facilities, some in Ontario and Canada and other places have moved towards sort of a mask for all approach within that environment. I don't know if you want to discuss the rationale for that and sort of how that's evolving as well.
Yeah, I think that's becoming the norm in the hospitals. People are wearing a mask for a day, or at least for a half day, for that very reason, because you don't know if you're a carrier, and it's a matter of breaking any chain of transmission. But it is a surgical type mask, so it also protect you from exposure to other people.
Yeah, and I have a lot of respect and sympathy for my infection control and public health colleagues, because this is one very sneaky virus. And, this difference, for example, between SARS-2 coronavirus and the original SARS, this whole issue about the asymptomatic infection and even potential transmission has presented a huge challenge, I think, for identifying cases and, preventing outbreaks for sure. Yeah. Just going to shift gears a little bit, and I was going to bring Dr. Slutsky in, if you don't mind, Art. I was going to ask a little bit about your thoughts on vaccination, because, as we start thinking about different strategies to try to prevent transmission and figuring out how do we kind of move to the point where, we're not putting everybody at risk in society from this particular virus. What are your thoughts on sort of innovative strategies towards towards vaccine production and deployment, or any other comments you have on that?
Yeah, so certainly I think that's the long-term answer. I mean, I think that's if there was a vaccine out now, we'd feel a lot better, clearly, because that's what's really required, I think, to get us back to the old norm, not the new norm. I just saw something recently. There's about 102 studies or people or companies that are making vaccines, and that's internationally. And 8 of them have been approved to start to do trials in humans. So that's moving so much faster than it has in the past. I mean, in the past, it's, as you know, it's years and years and years before vaccines get approved and tested. So that's moving along quickly. I mean, when will it be? I don't know. There's innovative things going on in Canada in terms of vaccine development. The group at Oxford in the UK are moving really, really quickly. They started to test, and it's a matter of testing to make sure it's safe as well as effective. The problem, of course, is, let's say that there is a vaccine in a year, maybe less. It could be the end of this year. That would be really early. So that's great. We talk about making millions of vaccines of doses available. Well, there's 8 billion people in the world. Like, how do you actually then, let's say we had the vaccine today, when is it actually going to be available for use around the world. When are we going to get it? And you know, Bill Gates is doing some interesting stuff, right? I mean, he's I think paying for something like 8 factories to make different vaccines, knowing that probably 6 or 7 or maybe all 8 aren't going to work, and essentially throwing away billions of dollars. But you think about what this is costing in terms of lives, what it's costing in terms of the economy, that's a pittance. So I think that sort of strategy makes a lot of sense. Governments will probably be doing that as well, because each government's going to want to produce vaccines for their people, because, you know, if it's made in the States, I don't think we'll get too many until they've vaccinated 330 million people, right? So I think that, and I know the governments are thinking about that. So there's a lot of innovative approaches. When it'll happen, it's really, really hard to know.
And I wonder if you could comment a little bit on some of the new research coming out on potential treatments. And it's been a very interesting experience as this whole pandemic has evolved, between press conferences, social media, and I won't get into the politics of some other countries, but certainly, you know, with politicians and statements about what works and doesn't work. And any comments on what's been different about sort of the approach to research for this pandemic, and how we're identifying sort of what treatments might be helpful and working and which ones might not?
Yeah, so I think there's, Randy, there's great news and there's terrible news about it. The great news is, you know, people are really working together. I've never seen researchers around the world who are working so closely together, sharing data. Everybody wants to make this work. I was on a couple calls today where the idea is there's 3 or 4 studies looking at given drugs, and usually people would do it on their own and then publish on their own. We're talking about how do we get a common data committee to look at the results as they're coming in from all the studies together. And when there's enough data to say the drug is effective, stop the study. Don't wait till each study finishes by itself. You know, similar to that is, you know, in case there's side effects of the drugs, we can stop that much sooner. That's almost unprecedented, and certainly it's unprecedented at the level that it's happening. If you look at the number of publications, you know, I remember seeing something in Nature by January 31st, there was something like 60 publications in peer-reviewed journals. I checked yesterday, I think there's 8,000 publications in peer-reviewed journals. So that's good and bad. I mean, there's a lot of stuff that's coming out that's not very good, even in the peer-reviewed journals. But I think one of the downside, of course, is that there's so much anecdotal stuff. There's so much on social media. I'll give you one example, was the ibuprofen story of a few weeks ago. Remember, there was what it started off as a letter to the editor in Lancet Respiratory Medicine, suggesting that ibuprofen might be harmful. And then the French government went out the next day and said it was harmful, and 2 days later said they didn't have enough data. And it was essentially a theory, but people are grasping at straws. Now that was sort of something that was, if you like, negative, but there's all these, you know, new therapies that people are talking about. Vitamin C, as you know, Randy, in critical care, you know, vitamin C has been suggested as a cure-all for septic shock. And there's a couple of people touting that, you know, around the world. Very little data. There was a small study of 20-25 people that looked like it might be effective. In January in JAMA, there was an article, a study of about 200 people showing it wasn't effective. So there's a lot of this, you know, we have to do something. It's that sort of attitude. And I think the way to do this is, you know, ideally every patient, or that's not going to happen, but most patients should be in some clinical trial. And in Canada, there's a lot of clinical trials going on. So there's a lot of opportunity for patients to be in clinical trials. Let's learn something from any therapies, because if we don't, it's terrible. We think we're doing something. We all want to do the best we can, but it's actually can be really detrimental. I'll give you one small example, then I'll stop. I'm doing a study. I'm helping a colleague in Spain do a study on steroids for severe ARDS patients on a ventilator, and we entered about 20 patients quickly in 2 weeks. Fantastic. We haven't any new patients in the past 10 days. All the patients on the ward now are being put on steroids. So if that happens, we're not going to learn anything. We won't know if it's advantageous or not. And we might be helping patients, we might be hurting patients. So I think we need to get evidence. And there's, as I said, there's lots of trials ongoing. The government's actually supporting trials in a big way like they haven't before. So that's my push to sort of, let's do things that are evidence-based. I understand the need when you have a patient in front of you to do everything you can but we could be doing more harm to many patients than good.
Yeah, it's interesting. The hydroxychloroquine story has been very interesting. So I've never seen something come in and out of fashion so fast. I can say that certainly the early COVID-19 patients that I was looking after were getting started on hydroxychloroquine, on the medical wards before coming into the critical care unit. Within 2 weeks, suddenly it all stopped and nobody was on it anymore. And it's interesting too, because all the reports of cardiac arrhythmias potentially related to, the combination of hydroxychloroquine and azithromycin, both drugs that were being routinely prescribed for patients maybe 6 weeks ago, not being routinely prescribed anymore. And, we worry about how many patients actually ended up having these cardiac arrests from drug side effects from these arrhythmias. So I think these issues aren't just theoretical. I think these are real, and we've seen this in live action.
Look at all the patients who need hydroxychloroquine who couldn't get it because it was all just gobbled up. That's terrible. It's terrible.
Randy, can I just
go ahead?
No, go ahead. No, I just wanted to throw out when it comes to sort of research and treatments, there's these three big buckets. There's the public health measures and research into what kind of physical distancing works, what kind of contact tracing works, and then there's the treatment of the most acutely ill, those on respirators or those in admitted to hospital, of which there are a whole bunch of agents. And then there's a paucity right in the middle, which in theory hydroxychloroquine was touted as one of those that can prevent symptoms are getting more severe. I'm part of a group that's studying another drug in that middle bucket, trying to prevent things from getting more severe, which I think is a really critically important piece that people aren't always thinking about. If we can prevent things from getting more severe, you immediately dramatically increase the healthcare capacity or what is needed, and then you can actually open up for business and decrease the social distancing earlier. So, those three buckets of different types of research and treatments are really important to look at distinctly in terms of looking at the public health approach to the pandemic.
And actually, Barry, since I've got you connected and looking forward to your comments as well, I've had some questions asked about this whole concept of herd immunity and how that potentially fits in and really what that means. So I wonder, I don't know, Barry, if you want to start, maybe just a definition of what are people talking about with herd immunity and how does that sort of fit in with our whole public health approach to COVID-19?
Yeah, I mean, herd immunity is just really important for, looking at how diseases spread in populations. And of course, it's when someone has had disease, for some diseases, and most certainly not all of them, one becomes immune to some degree from becoming reinfected. And once a certain proportion of the population has that immunity, then you're not going to see spread person to person. And it very much differs on the reproductive capacity of the virus, or in some cases bacteria in question. So measles, you need somewhere in the neighborhood of 95 to 97% of people to be immune in order to prevent transmission because it's so transmissible. Influenza, you need quite a bit less. And the SARS coronavirus, as many of us know, has a reproductive number around 2 to 2.2-ish. So for every one person who gets it, they pass it on generally to 2 people, and the herd immunity can potentially be useful in lowering that number. I'm sure Anne is going to chime in here, but what I can say about it is that those who are claiming that it is a terrific idea for everybody to get sick and therefore we'll all be immune and therefore we can open everything up is a very unproductive approach to this issue from a public health perspective, and will lead to many more deaths than otherwise. Whether there is short-term, medium-term, long-lasting immunity for those who've had disease, what that really means, what proportion of the population have been infected, is still really very much to be seen. Once we get serology testing out in the population, which we will at some point reasonably soon, we'll see somewhat what that means. Other countries are ahead of us in terms of the pandemic overall and ahead of us in terms of that kind of testing. And we have the advantage that we're going to be able to learn from them. So there's a lot still to be learned there, but those jumping to quick conclusions are not correct. Let's just go out and say that.
Anne, did you want to comment as well?
That was a great explanation. Really nothing to add except that that's Sweden's approach, right? They're looking at herd immunity by not doing the tight lockdown scenario. But if you look at their population, which is similar to Israel, and the number of deaths that they've had 10 times as many deaths. So there is a cost to pay when you let people just walk around who are infectious.
Yeah, I think a pandemic will burn out in a certain location one way or another, but you're trying not to have a lot more dead people in the process. So yeah, I'm glad we haven't taken a herd immunity approach to this in Ontario and Canada. I'm going to shift gears a little bit, Gary, if you don't mind. Just wanted to ask you a little bit of a question related to what's happening sort of in primary care and how that's sort of interfacing with the emergency department. And I know we've been hearing messages and observations that I don't think before this pandemic we've ever heard, which is the emergency departments are empty. That's a new thing. And just wondered if you wanted to comment on messaging to the public about, how does the emergency department fit into what our health system in the context of the pandemic, and also what things have been done to sort of extend the expertise of the emergency department outside the walls of the hospital. And I don't know if you want to talk a little bit about how emergency medicine is fitting into assessment centers, long-term care, that sort of thing.
Sure. Well, let me start off with the current reality. Most emergency departments in the province are seeing unprecedented low volumes of emergency patients, somewhere in the neighborhood of sometimes even less than 50% of our normal volume. Things are slowly starting to pick up a little bit more, but the big message out there is that the emergency departments are not closed and they are not restricting patients from coming in, and quite the opposite. We're very concerned about people possibly sitting at home with an evolving myocardial infarction or an evolving appendicitis, but that they are, for whatever reason, afraid to come to the hospital because they think that they're going to have a higher risk of infection. And the message that we need to send out to the public is that the emergency departments are open for business everywhere, and that people should not shy away from the emergency department if they have what they consider to be a real emergency. And if they would have come to the emergency department with whatever that problem is in normal times, then they should not be hesitating to come in current times. In terms of how the emergency department is helping outside of its walls, I think one very big area is the long-term care situation. Everyone has probably heard about the outbreaks that we've had in Pickering, at Orchard Villa, and some of the other long-term care facilities in the GTA. And part of the problem is that there hasn't been a lot of medical direction in dealing with these. Now we have the assistance of the Canadian Armed Forces, and just as one example, the hospital that Randy and I work at, which is Lakeridge Health, has been directed by the medical officer of health for Durham Region to actually take over the medical care of a certain number of long-term care facilities to try and stave off the devastation of the outbreak that they've had and the large number of deaths that they've had proportionate to their number of residents. So, we have moved in there to tour the facility, to try and advise on what can be done to cohort the patients that are positive away from the patients who are negative, the symptomatic patients from the asymptomatic patients, and also to move in some of our own nursing and patient care representatives and workers to help in that environment to try and reduce the number of transfers that need to come to hospital, which is not helping the patients and is not helping us.
Yeah, and certainly on the critical care side, the number of patients affected in long-term care facilities, it's been huge, and the emergency department side as well. And I think the extension of the hospital teams to help work with long-term care facilities has made a big difference in terms of, trying to prevent unnecessary transfers to the acute care hospitals, when you don't have to. And also, I think in some of the patients who maybe have a lot of complicated medical history, who, if they got critically ill, would not do well in a critical care unit, for example, on life support. Having those sorts of discussions with patients, or if they're unable, families, to have a plan in place in case they do get sick has been, I think, important in making sure that we're providing the appropriate care for patients. I know our hospitalists, for example, at Lakeridge have done a great job of working with the teams in the long-term care facilities with that as well. And just for 2 seconds, if you don't mind, about infection control, just wondered if you wanted to comment a little bit on some of those the challenges of infection prevention and control, translating what we do in the hospital environment to long-term care facilities, and any thoughts or comments on that?
Well, actually, one of the biggest problems we have is trying to train the staff to adhere to very strict infection control procedures. When we toured one of the facilities last week, we were kind of shocked to see that they were not cohorting their sick from their not sick patients. In some cases, there were residents in a double room where a double occupancy room where one of the patients was positive and the other was negative. So this was really appalling to us, and also the fact that the staff really didn't have.
Oh, I think we lost Gary there for a sec. Sorry, Anne, I was going to get you to comment as well. We'll see if we can get Gary back. Go ahead.
Yeah, the whole long-term care environment is so different than what we're used to in acute care, because it's the person's residence. They bring their dresser from home, often in their favorite chair, and their books and their whatever, little mementos they have of their life. And the rooms are often very cluttered. They're difficult to clean. Hygiene may not necessarily be the best for the patients, so it is very difficult to get on top of it from that perspective. It's just a very, very different environment. People who are well-trained for infection control and less well-trained, given the number of casual staff that go through those centers, who may not be used to the requirements that are given long-term care, because there is variability. So in a way, it's sort of like the Wild West out there sometimes, and it's sort of no surprise that they ran into the trouble they did. Apart from the vulnerable population, it's just the mechanics of the way the homes work.
Barry, did you want to comment a little bit on sort of public health and how that interface with long-term care?
Sure. So the whole edifice of the way public health interacts with clinical care interacts with long-term care is really kind of complicated, and the municipal, provincial, federal, and the healthcare sector is really complicated. Right now, public health has been charged with doing surveillance, among many other things, within long-term care facilities. So every health unit is addressing that issue slightly differently and mobilizing our resources to get in there, and whether it's do testing or support staff. We've got our in the region I work in, we've got our dental hygienists training up to do a lot of testing in long-term care facilities. There are congregate settings, long-term care facilities, homeless shelters, childcare settings, depending on where you are really our priority right now in public health for aggressively going after and preventing outbreaks, and the rest of the general population is where we're doing vigorous contact tracing.
And it's ironic, certainly in Ontario, there were plans, with Ontario Health and the evolution towards trying to create sort of a seamless healthcare system. That was certainly the intent. I think we've been forced to accelerate some of that seamlessness, unfortunately, in a rapid response to the pandemic. But I would say it's been very reassuring to see that, when acute care hospitals, long-term care facilities, retirement homes, public health, primary care, when people are working together, seeing a rapid difference, I think, in the ability to look after patients and protect patients and to get some better control of the pandemic.
Randy, there's been,
Go ahead, Gary.
there's been a question raised about pulse oximetry and
Sure.
whether you would recommend the use of pulse oximetry for early detection. So my feeling was that pulse oximetry in most cases will not help with early detection, because we know there are a large percentage of COVID-19 patients who are positive but completely asymptomatic. Their O2 saturation will be at their normal baseline levels, if I'm not mistaken. But if a patient has comorbidities such as CHF or COPD, and they regularly monitor their pulse oximetry, that would certainly be a practice that they should continue, because if they start to deteriorate, their pulse oximetry may or may not give them early warning signs. Now, this is more up your alley, so I'll let you comment further on it.
Sure, and I'll bring Art into this conversation as well. COVID-19 is a very odd disease, and so one of the terms that's relatively new for a lot of clinicians is this idea of the happy hypoxic patient, the ones who look not that sick and they're not in respiratory distress, but then when you actually use pulse oximetry to look at their oxygen saturation levels, they are surprisingly low. You know, from a critical care perspective, a lot of the evolution and the management of patients presenting with sort of more serious or critically ill COVID-19 initially was sort of rapid progression to mechanical ventilation for all these patients. And what's been really interesting is hearing the experience from Italy and from New York City about the idea of using less invasive strategies for managing these patients short of mechanical ventilation with other devices like high flow nasal oxygen, or in some places non-invasive ventilation, although recognizing that there may be some potential infection control risks with that. Art, I don't know if you wanted to comment on that, because I know you've got some close ties with some of the experts in Italy, Dr. Gattinoni and others, and I don't know if you wanted to comment on the odd nature of this disease from a respiratory perspective.
So it really is odd, and you know, Gattinoni's had this hypothesis that some patients actually don't have stiff lungs, they have relatively compliant lungs, you put them on a ventilator and they're into trouble. The data to support that is sort of not entirely there. The happy hypoxia piece is pretty interesting, and the control of breathing is pretty interesting. And it might be related to the fact that the virus gets into cells through the ACE2 receptor. ACE2 receptor sits on cells, sits in type 2 cells in the lung, sits in cardiac cells, but it also sits in the carotid body. And maybe what's happening is the carotid body is getting infected, and therefore you lose the sense of dyspnea. And it could be affecting the centrally as well, control of breathing, more related to carbon dioxide, because that is pretty unusual to have people that are sort of grossly, very hypoxic and feel fine. They don't feel quite fine, but they're not really short of breath. So in those patients, I think Gary's right that, you know, having an oximeter potentially for those patients who have comorbidities, this might be helpful. I mean, if your saturation is sitting at 95, 96 all the time, and you have COPD, and then, you know, you check it and it's now 89, even if you feel okay, you should be seeing a doctor. And, you know, if you go to the emerge now, you might be able to be seen pretty quickly. So it's a very unusual disease. The other part that's really unusual is we think of it as a respiratory disease, but it's been clear in the last little while that it's, you know, it's much broader than that. It affects the kidneys, the cardiovascular system. There's microthrombosis that appears to be a really huge issue, and macrothrombosis with young people getting you know, problems in terms of ischemia to the brain. And I think that's what's affecting the lung as well. That one of the reasons for the hypoxia is microemboli or microthrombi, which aren't classical ARDS. So it's a very complex disease, and you know, I think a reasonable way to think about it is sort of where does the ACE2 receptor sit, and those are the organs and the cells that seem to be affected, whether it's the kidney, the heart, and the blood vessels. You know, this, you know, COVID-19 toes, that kind of thing.
What's been very interesting as well for managing critically ill patients is the whole issue about prone positioning, and certainly that's a life-saving intervention for people on mechanical ventilation when you just, no matter what you do, you're having trouble getting the oxygen saturation levels up to where you need to. And certainly, you know, we've done that for many years for patients with acute respiratory distress syndrome who are severely ill. What I'd never seen before, which is very interesting, is this whole issue about awake self-proning for these patients on high flow nasal oxygen. It's been very interesting hearing these reports out of New York City, for example, where patients who are on the high flow nasal oxygen, we're actually instructing them to go ahead and flip over on their front and actually seeing some significant improvements in oxygenation. Have you ever seen anything like that before, Art?
No, I just was at one of these Zoom seminars yesterday, and someone showed the data of a patient whose saturation was like 85, 86, not intubated, prone themselves, and saturation went up to about 95%. So there's a couple of trials, at least a couple of trials. Certainly there's a couple in Canada that are ongoing, looking at patients very early on. One out of Mount Sinai, which you know well, Randy, very early on, to see whether that can improve outcomes. So it's very interesting phenomenon. We sort of understand it, I think, in ARDS. Don't quite understand it completely in COVID-19, other than it is, you know, it can lead to an ARDS-like picture for sure.
It's been very interesting. Anne, I'm going to flip over to you for a second, just given your relationship with the Hospital for Sick Children. And I don't know if you wanted to comment or Barry or anybody about the reports coming out about Kawasaki-like disease or some of these interesting manifestations in children. And so maybe if we just take a minute, because there have been a number of questions about the pediatric side of things, whether we could comment a bit on COVID-19 in the pediatric population. I know there's been a little bit of press about a couple cases at Hospital for Sick Children and some interest in that. So, Anne, maybe if I could start with you, if you want to comment on how this sort of fits in with kids.
Right. So thankfully, children don't get the disease as bad as others do. A lot of children are asymptomatic, so can be a big reservoir in the community. The relationship with Kawasaki disease is really interesting. So this is a disease presumed to be infectious, first described in Japan, which is the derivation of the name, but one of the hallmarks is coronary aneurysms. So whether that has, usually due to an inflammatory etiology, we know the whole inflammatory system is revved up in COVID-19, and whether the microthrombi have anything to do with that as well. But it really is an inflammatory state that manifests with some organ involvement, most particularly the coronary arteries. One of the comments by somebody at the hospital was very interesting in terms of calling an outbreak at sick kids, which I just would like to highlight. The definition of an outbreak, as Barry, you will correct me, but the general definition is an increase in incidence above the usual rate. So in that, the usual rate of acquiring COVID should be 0, that theoretically, if you have one case of COVID acquired in hospital, that constitutes an outbreak by public health definition. So the patient, I understand, was an immune compromised patient. A healthcare worker caught it. There's another case in the hospital that I gather was unrelated, but given the vulnerable population that was involved and the fact that a healthcare worker supposedly got it from that patient, again, this opens the quagmire of when you diagnose it in a healthcare worker, can you be 100% sure they acquired it in the healthcare setting as opposed to on the outside? So it is often circumspect, although if this is the only obvious exposure, the thinking is probably that it is a nosocomially acquired case, if that's what the infection control people have said. But that's the short, that said, kids are not exempt from having serious disease. So especially under age 1, symptoms are a lot less common, whereas adults get cough and fever 50% of the time, 80% of the time. It's about 50% of the time in children. But if there is an illness that a parent is concerned with, they should clearly call their pediatrician or primary care physician for help.
So staying with the pediatric theme, there have been a number of questions forwarded prior to the webinar about summer camp. And I know, you know, this is something that a lot of folks in the community have a tradition of their kids or having gone themselves to summer camp. And I believe there's a number of announcements that have been coming out about, you know, cancellations for the summer or potential cancellations. And just wondered, maybe to start with Ann and Barry to talk about from, you know, an infection control and public health perspective, why it is that, you know, not going to summer camp or canceling that is a good idea and an appropriate idea. And then after Ann and Barry, you comment, Gary, I know you've got a lot of experience as well as a summer camp doc, and so maybe we'll get your perspective on that as well. But Ann, why don't I start with you, your comments on that?
Sure. Again, you have a situation where children are very close together. They don't understand this 6 feet of distancing. Some of them can be asymptomatic. You don't, and as people say, they're little germ bundles. Their hygiene is not very good. Their ability to hand wash is not very good. So I hate to say you can't trust them when it comes to situations where infection control is of a concern. And it would be hard to think of a situation where children would be close without some contact with the outside camp world, be it staff that would go for a day visit somewhere or family day where they all come up. It's just a risky situation. It's 1 step away, 6 degrees of separation from someone who might catch it and get terrifically unwell. And I think the public health implications really override the whole, unfortunately, the whole summer camp experience. So I'll pass it to Barry.
So yeah, lots to say as someone who attends camp as a camp doctor regularly, and very much looking forward to it. I think I'm just going to step back a bit with the public health measures and how we're going to return to normal. The province has put out actually a really great framework for doing so without timelines, but a nice sort of outline of where we're going with this. And the phase 2, which is when we start opening up, has a number of stages. And gathering together large numbers of children from various parts of the province, from various different countries, 25 to 30 of them in small areas, sleep deprived, is the last stage. It's along with having, university classes of 3,000 people or big concerts. That is something that you only do, regardless of really whether children are major spreaders. It's something you're only going to be doing at the end of this. So there are a lot of things that are going to be happening first. I think it's important to note that also in stage 3, 2.5, 3 is opening of places of worship. So a big issue for the community that I deal with on a daily basis is people going to Minyan, going to shul, or wanting to go to shul, or all these, literally hundreds of, or potentially hundreds of backyard minyanim, certainly going on in places like Lakewood in Israel, but certainly also several going on in Toronto, mostly outdoor, mostly adhering to so some guidance around that, but getting back to shuls even by Rosh Hashanah and Yom Kippur in large groups it may or may not be happening. So that we've already got some guidance where there's a task group in the Jewish community called Kol HaKoved that's has put together some guidance on many of these things, and a number of rabbis in the community as well. So in whether it's camp or other large gatherings, those are going to be quite far in the future. And even once we go back to what would otherwise be normal for the general population or approaching it, many things, certainly for the observant community in Toronto, but for everybody from a Jewish perspective, are going to look very different.
Harry, I think it's worth mentioning that that funeral in New York a few days ago, where there was, 1,000 or 2,000 people, was, I thought, outrageous. I mean, I think we should call it that. It's just outrageous to have that many people together, especially in a community that's been affected. That rabbi who died of COVID-19. I think that's just unacceptable. We can't accept that.
And Gary, I'm going to just float back just for a second to the summer camp thing. So a question popped up on the chat group, and I think it's an important question to answer. So if camps are ongoing in other jurisdictions where maybe they are going to loosen things up a bit faster than we might in Ontario, let's say, or Canada. Should we send our kids to camp in New York, for example, was the question. So what would your advice be?
So the Union for Reform Judaism made the very difficult decision today. In fact, it was announced that they were canceling summer camp for all of their camps in Canada and the United States. That there really was no safe haven for kids to attend camp, not only because of what they would be coming into, but also from where the kids are coming from. And we know that there is asymptomatic carriage in this disease. And the other thing is, having worked in camp over the last 18 years with outbreaks of H1N1, outbreaks of viral gastro, and you know, things such as that. It's no fun for the kids. It's no fun for the staff when you have to start quarantining people. With a virus such as this one, it would be impossible to quarantine anybody except the entire camp. And it would not be camp as they know it and as we know it. At this point, unfortunately, it's no safer to open up a camp even in Wisconsin or maybe in, I don't know, Oregon, than it would be to hold Major League Baseball in Arizona at this point.
And, you know, I think as far as looking at different jurisdictions, just as we get ready to wrap up, I do want to say that I don't know if people in the public appreciate how, and I'm not going to say it's lucky, but it may be fortunate or whatever you want to call it. We've been in Ontario, for example, and in Canada to not experience some of the horrible things that they've experienced, not only, you know, for example, in Italy and in China, but even a place as close as New York City. And I know all of you as healthcare professionals, certainly for me, hearing the stories about critical care physicians and other doctors, the experiences they've had having to manage, you know, just an excessive number of sick patients in some of these other jurisdictions that are very close by, it just horrendous stories. And so I do, you know, think that we're very lucky in Ontario and Canada to have not only great experts such as yourselves, but lots of folks working together, whether it's in the hospitals, long-term care facilities, primary care, everybody working together, and the government, and in particular the public. We would be in such worse shape if it wasn't for the cooperation of the public in the physical distancing and working on the measures and being patient to understand that it's going to take time before we get back to, you know, to normal. And in fact, there's going to be a lot of things that are probably going to be different. I think we're going to learn a lot of lessons out of all of this, and whether it's in healthcare or other aspects of society, I don't think things are ever going to look the same after all of this. We've learned some valuable lessons. We're just getting close to the end of time, and I want to thank everybody for the incredible comments and insights. And I do recognize there were a flood of questions coming on the chat page, and a lot of questions we weren't able to get to sent in even before the webinar, and I apologize for those of you whose questions weren't answered. Hopefully we'll be able to do something like this again soon. And I want to thank everybody for participating. Just for a few wrap-up words, I just wanted to pass it on to Dr. Max Weisbrod. He's the co-chair of the healthcare division of the UJA and also a community family physician as well. And Max, maybe we'll turn it over to you for a few final words.
Yeah, thank you, Dr. Wax. And I thank you so much to everyone on this esteemed group. Really found this to be extremely insightful and engaging, and I hope everyone enjoyed it and learned as much as I did. I just wanted to quickly mention UJA before we sign off for the evening. As Leonard mentioned at the beginning of our call tonight, the needs of our community are greater than ever due to the pandemic's impact. UJA is focused on ensuring our community comes out of this pandemic as whole as possible. And if you are in any position to make a gift today to UJA, I can't encourage you enough. UJA is a crucial part of our community, and ensuring their success now is ensuring our community's future. A link has been provided in the chat window section of this webinar and will also be included in the email you will all receive tomorrow with a link to the recording of this webinar. Further, if you have any questions, please reach out to any UJA professional. We've also included Jen Apple's email, who is one of the UJA professionals, in the chat as well. Thank you all very much, and have a great night.
Great, and thanks to the UJA for hosting this, and Barry, Art, Gary, thanks so much everybody for your comments and your participation. It's greatly appreciated.